Dr. Heloisa Soares is a medical oncologist from Huntsman Cancer Institute in Salt Lake City. Her presentation is on systemic therapy for NETs, treatment options for metastatic tumors. Her fun fact is that she's obsessed. She says she's obsessed about camper vans. She's watched a lot of YouTube videos about choosing the best camper vans, yet she does not yet have one. But she's rented an Airstream camper. The reason she has to go take a flight is she's going to be camping in Moab tomorrow with her 2 kids and her husband. So welcome, Dr. Soares. Thank you so much for being here.
Hi, good afternoon, everyone. Thanks for having me. Thanks for having me back in one of the events. And yes, if anyone has a camper van, I'm all yours. I want to hear more because I can't decide which one I want to buy. So we just rent a trailer for now. And yes, it's my kids' spring break. That's why it's the balance of life, right? I want to be here, but I want to also be with my little kids. So we will talk a little bit about systemic treatments. And so the first thing that I wanted to do is actually stop and talk and say, what are systemic treatments, right? I mean, systemic treatments, what is this? So are any treatments that are drugs or therapies that will travel through the blood stream to target the cancer cells to the body? It's not radiation, it's not surgery. And then it's designed in theory to work everywhere or reach everywhere that the cancer is most of the time. And the goal is to slow the tumor growth, reduce the symptoms. If you have carcinoid syndrome, maybe could reduce the symptoms or any pain because your tumors are big, and if you shrink, the tumors can get better and improve your quality of life. Again, here is just, you want to live longer and live better, or one of the two, right? So this is the goal when we choose systemic treatments. So how to decide on the systemic treatment that one should have depends a lot of things. Depends on the tumor characteristics, depends on the overall health of the patient, peripheral preferences of the patient, sometimes drug interactions, and really a multidisciplinary approach, because there are occasions that surgery resection is actually the more appropriate option, or embolizations to the liver might be much better. So it's really, we need to see when to use the tools that we have. And just to give you a context, I think it was just mentioned before, they're not one size fits all. This is, all these patients, if they come to me and say, define what type of tumor do you have? Well, I have a well-differentiated small bowel tumor that is metastatic. So all the little whites, or most of the whites, this is the bladder. The bladder tends to be always positive, but all the little whites are tumors. You see here the liver of this patient is full of tumors, and then here very little, and then here a little bit more. Guess what? These patients were treated completely different for the next treatment decision that I had to make with my multidisciplinary team, exactly because depends a lot on all of these things to make me decide. So just because you have a well-differentiated neuroendocrine tumor in the small bowel that's metastatic does not mean that you're going to get the same treatment that your neighbor that's sitting in the waiting room waiting for the treatment. For neuroendocrine tumors that are well-differentiated, we break down in typically 4 different categories. And I excluded immunotherapy because immunotherapy tends to be the exception of the rule. So we will start with somatostatin analogs, which is the hormonal shots, the ones that you know is octreotide and loriotide, commercially available as sandostatin or somatulin. They mimic the natural hormone that slows, grows the tumor growth and controls symptoms such as the diarrhea and flush. That's the one that you get, the long-acting you get in the butt, and you alternate the buttock that you get your shot once every 4 weeks. If patients have a lot of symptoms, they might be doing the shots a little bit more frequent if they are on loriotide, or they might even be more frequent or in a higher dose if they are on the octreotide. The octreotide can go up to 60 milligrams every 4 weeks. If a patient is having flares of the symptoms when, let's say, in 3 weeks versus until the next shot is doing 4 weeks, there often we try to do it every 3 weeks to help with symptoms, but the way that it's approved is every 4 weeks. And really, it helps to control the slow growth of the tumors and the symptoms. Side effect. Most of the time, they tend to be mild. They can get a little bit of nausea, fatigue, sometimes headaches, a little bit of mushy stools. It's not really diarrhea, it's more mushy stools, so pancreatic enzyme deficiency. So if you have a sort of oily, you see undigestive or foamy stools, and particularly when you have heavy meals, you might be having the side effect of pancreatic enzyme deficiency from the shots. The sugars can go high, very rarely can go low, most of the time is high. And then if you still have your gallbladder, chances are at some point you might develop gallbladder stones. So if you're going for surgery and your surgeon is familiar with neuroendocrine tumors, there's a very good chance that they will offer to actually to remove your gallbladder at the time of surgery. These are the two big studies that showed the benefit of these drugs. One is not better than the other. The characteristics of the patients that were included in these studies is different, and this is not also survival data. This is progression-free survival, which Dr. Combs is going to talk to you a little bit later of how to interpret the data. But this is how long it takes for the tumors that you have to grow a given percentage and to see new tumors. And both studies show that the shots are very good in controlling tumor growth. Then we have the target therapies. The target therapies, even though it's called a target, it is not necessarily target to a given mutation in the tumor. It's just about targeting the blood supply and the tumors that are troublemakers and slow down through attacking some signaling pathways to slow down the tumor growth. There are many therapies that do not require the tumors to have mutations. And the examples that we have of target therapies, in this case of tyrosine kinase inhibitors, are sunitinib, everolimus, and cabozantinib that we have here. So we start with everolimus. Everolimus tags a pathway that's the mTOR pathway. It has shown to slow down tumor growth. Does not do a great job in shrinking tumors, but is good in controlling the tumors and delaying them from growing. Side effects, you can feel tired, the mouth sores, diarrhea, rash, high blood sugar. Sometimes you can see a pneumonitis, which is inflammation in the lung. For the mouth sores, there's some tricks that we use that we took from the breast cancer patient populations, that we use dexamethasone as a mouthwash, and then patients spit. We do that typically for the first 8 weeks of treatment, and then if patients do well and they don't have mouth sores, then maybe we don't need to use. Another, personally, that I use a trick is I start the everolimus at 5 milligrams and half of the dose, and I just go up as patients tolerate it. But this is personal preference as a clinician that takes care of patients. Your clinician might start you on 10 milligrams and dial down if you have symptoms. These are the studies that have looked into why everolimus is good for patients with neuroendocrine tumors. Starting patients that had carcinoid syndrome and metastatic tumors. Then there was a study in pancreatic neuroendocrine tumors, and then later was a study in neuroendocrine tumors, including in the lung, pancreas, and GI, that did not have any carcinoid syndrome. And in these studies, you can see that the patients that receive everolimus compared to receiving a sugar pill did better in terms of delaying the tumor growth in typically about a median of 11 months, which again, Dr. Kunz is probably going to explain later, but the median means that half of the patients did better than that and half of the patients did worse than that. It does not necessarily mean that 11 months is your particular benefit for the drug. It's just that when we get the pool of all the patients, we see that. Then we have cabozantinib that was actually just approved this past week by the FDA to be label indication in patients with neuroendocrine tumors. It has been incorporated on the guidelines since the beginning of the year because the data was presented last year in the academic oncologic cancer meetings. And it's also another pill, it's a TKI. It kind of works by reshaping the blood vessels related to the tumors. It's a pill that you take daily. Side effects, you can feel tired, diarrhea, rash, the high blood pressure is an issue, might have issues with wound healing, so there's a little bit of time after a surgery that you have to wait until you restart the medication, 2 weeks by the label. And before, if you're going for a surgical procedure, the label says you should hold the treatment for 3 weeks, but there's data in the renal literature that say only holding for 2 weeks is safe. You can have the irritation in the hands and the soles. That is this redness and blisters that can occur as well. Most of the time, it's just the tiredness is something that patients feel. You started typically the way that it has been approved by this study where patients that had pancreatic cancer, pancreatic neuroendocrine tumors, or outside of the pancreas, meaning that the tumors started outside of the pancreas, they were randomized to receive sugar pill or the Cabozantinib. And if the patients later, the tumors had progression of disease, and then they would know which treatment they were receiving. If they were receiving the placebo, they were allowed to then receive Cabozantinib at that time. Again, there was a study in a population that had received a lot of treatments in the past, and despite of having a more advanced populations in terms of their treatment history, there was the study showed the benefit of these patients from receiving Cabozantinib compared to placebo. In the patients that the neuroendocrine tumors start outside of the pancreas, the benefit, the median progression-free survival was 8.4 months versus 4 months, and in the tumors that actually were started from the pancreas, the benefit was a little bit higher with 13.8 months versus 4 months. Survival, there is no difference yet. It's a little bit too early to tell. So we'll see in the long term if we'll see any survival benefit. For studies in neuroendocrine tumors, particularly in their well-differentiated neuroendocrine tumors, it's really hard to prove survival benefit because thankfully patients live for a very long time, and then it's hard to have that long follow-up. So many of our studies that led to FDA-approved indications are based on improvements in progression-free survival. Again, how long the tumor grows, not how long the patients live. Then we have chemotherapy. Chemotherapy destroys the cancer cells and prevent them from multiplying. In neuroendocrine tumors, we use mainly either in the IV form or by mouth. Most of the time is actually by mouth. The traditional side effects of chemotherapy are fatigue, nausea, vomiting, sometimes hair loss, a weakened immune system because the blood counts can go low, mouth sores, changing the appetite or the taste of the food, maybe metallic taste sometimes, diarrhea, and sometimes again blisters in the hands and the soles. The chemotherapy that we most use is and we use a lot in pancreatic neuroendocrine tumors is capecitabine and temozolomide. This is a report from the good responses that you can see in the top. Like, look at this patient. This was the liver of the patient when they start treatment, and then after the treatment, this is the response that they got. And then Dr. Combs and her colleagues from ECOG actually developed a study to really try to do a very well-controlled randomized study to understand that. And once they complete the study, they saw that indeed capecitabine and temozolomide was CAPE-10, was very beneficial for patients. And here the median progression-free survival, again, the time that tumors took to grow were 23.2 months, and with temozolomide alone was 15 months. Response rates with the treatment are very good, close to 40%. The TKIs, we don't see a lot of responses, but with the chemotherapy, which we use in pancreatic neuroendocrine tumors, we do. We do not use a lot of chemotherapy in the small bowel tumors. They tend not to respond well. It doesn't mean that we never use it, but it's a little bit more when we run out of options, because we know that these patients are not going to respond to that as well as we see in pancreas. Then we have PRRT, and I think you have more dedicated time on that. But PRRT is essentially liquid radiation. You have your somatostatin receptor here. Where is that? And then you bind that to a somatostatin analog or your Sandostatin, if I may, and then you bite radiation and you do liquid radiation and give it to the patients, and it goes directly where the tumors light up on the DOTA-TATE scan. This is an example of response of a patient that received PRRT. There are 3 studies that have been completed, very different from each other in terms of understanding the role of PRRT. And the bottom line, if all these studies do show that PRRT is extremely good in improving the median progression-free survival of these patients. These 2 studies either in patients that were progressed after Sandostatin or lanreotide, and in the second one in patients that have a little bit more aggressive disease and were potentially treated in the beginning, we see a good median progression-free survival and compare with higher dose of octreotide. There was a recent study, I apologize, this is literally a picture from my cell phone because it was presented 2 weeks ago on a European meeting that showed that when we compare PRRT versus Everolimus, which is a more active drug in this case, you see a benefit again of PRRT. So it's a very good option for patients in the appropriate scenario. So I just want to finish that again, every patient is different, and this is a marathon. This is actually a patient of mine that runs Ironmans and, does the whole thing with Ironmans. And then she actually had carcinoid heart disease, got her valve replaced, and she ran a Boston Marathon and completed, I think, like 4 months after her heart surgery. And she gave me permission to share the person. So you start with your tumor. If surgery is not part of the management, you start with somatostatin analogs, and then, if you go with TKI, depending on the case, or chemo, or PRRT, or embolizations, or trials, and the decision about what's the next step it really depends on your unique circumstances. So that's a discussion to have with your well-informed clinician. But once you exhausted one option, then you rotate and use something else. And again, this is a marathon. And what I tell my patients is the name of the game is keep alive and healthy until the next best treatment comes around. Because now we're going to be hopefully doing retreatment with PRRTs in the future if the studies are positive, which I think they will. Cabozantinib wasn't approved until last week, and now it is. So again, the name of the game, and be patient, work with your clinicians, and strategize your treatments, and just wait, because I'm sure the next treatment that's good is going to come. And I am a believer in clinical trials. That's what I have. This is some of my team at Huntsman, and my brother is not here today, but he was, and I empathize with all of you because 2 years ago he flew to the LACNETS to attend the patient group, and he is neuroendocrine tumor survivor himself. His tumors are all resected, and he's 36 years old. And then he asked me, what should I do with my life? Should I have another kid? And I was like, live your life. I got you. I will continue to do all this research and just keep alive. And if God forbid things turn bad, we will have new things for the future. And he really was happy to be in this meeting because he was like, wow, I'm not alone. It's so nice to see so many other folks like me. And I say, I know, right? You don't hear me. Finally he came. He came from Brazil, and he saw he was in the meeting, and was really eye-opening for him. So I see both sides. So thank you so much for being here. Thank you.
Thank you so much. I mean, Dr. Soares, it's personal, right? She's fighting with and for us, just like I said at the beginning. Thank you so much for being here, and safe travels back.